First of all, I'm going to talk about joint examination. So it's going to be a bit of a whistle-stop tour, sort of an overview of the major joint examinations, which is shoulders, hips and knees. And then we'll briefly mention hands as well, although that one's a little bit of a different examination. So what we're going to look at, so what is a joint examination? So what exactly qualifies as a joint examination? Hopefully give you an overall structure to fall back on for major joint examinations, and then to be aware of some special tests for each of the joint examinations. Of course, with any OSCE station, the most important thing to getting them right is to practice a lot, and practice on non-medical friends and family as well, so that when you're giving instructions on put your arm here and do this or whatever, it's interesting to see how someone who isn't aware of the examination responds to that. So lots of practice is the key. So the station might be set up something like this. So you're an F1 doctor on a GP rotation, and your next patient is 64-year-old Mrs. B, and they may have pain or they may have swelling in the left shoulder, hip, knee, hand, whatever it might be. And then they will ask you to perform an examination in whichever time period that you have for your OSCE. And then you will probably have to summarize your findings at the end. They may or may not tell you to perform a specific examination. It might say perform a shoulder examination. It might say perform the relevant examination. So it's sort of up to you to read that bit of information that you've got in order to make sure you're doing the right assessment. So what is the relevant examination if it's not said? So what you need to do is examine the joint. If the joint is painful, examine that joint. You will ask about pain. So before you get the patient to do anything, check if they are in any pain, so that what you're going to do, either they're aware it may cause more pain or that you can avoid doing that. You will offer to examine the normal side first. So in an OSCE, you might say, I'd like to examine the right side first, if the left side is the trouble, to see what normal is like. And your examiner will probably say, that's fine, just move on to the left-hand side. And so that's to demonstrate, so you can see what normal is for the patient, so you can compare any abnormality. But obviously time is critical in an OSCE. You want to have a structured approach. So this is if you end up getting confused, if you end up getting stuck, then if you can fall back to your structure, then that will help you along, and it will also show the examiner that you know what you're doing. And act with purpose. I've put this here so that anything you do, you want to do it properly, if that makes sense. So if you're going to assess, movement, you want to assess the full range of movement, and you want to do it properly, not with a sort of half-hearted or I'm not sure kind of approach. It's sort of the whole fake it till you make it kind of thing. If you act with confidence, then that will reassure both the patient and the examiner. Obviously, the best thing is to actually be confident and know what you're doing. So. And then things not to do. So as with any OSCE situation, again, don't panic, take a deep breath before you start, think your structure. In an examination station, there probably won't be any marks for taking a history. So don't be doing that. You can ask about pain, as I said, but don't fall into taking a full history, and don't fall into neurological examination. From my role as an education fellow doing mock OSCEs and things, I've seen quite a few of these where the station's been either or the other, so neuro examination or joint examination, and the two have been mixed up. Obviously, there is a little bit of overlap, but they are very different examinations. So does anyone have a structure for joint examinations? How do you go into a scenario like this? There should be something to enter in what you like on Menti. Look, feel, move, special test. Yeah. I think look, feel, move is definitely the mainstay. Does anyone think of anything else that they might want to think about? Gait, yes. Yeah, definitely for lower limbs. Inspection, palpation, movement. Yep. So similar to look, feel, move. Yep. Special test function. Yes, that was what I was looking for, function. So it's all well and good if the patient can do everything that you're getting them to do. But if they can't do what they want to do, then that's not right. Neurovascular status, yes, that might be something you want to offer at the end, but that sort of don't fall into the neuro examination. I don't know what AODL is. I've not come across that one. Activities of daily living, yes, yeah, function, yeah. So look, feel, move, and then think about function or special tests. So before you do any of these things, what you're going to do is prepare yourself and your patient. You may all have a different sort of mnemonic for this. I've seen people use WIPE. I've seen just this, prepare yourself and prepare the patient. But whichever way you do it, make sure you do it. So this is washing your hands, introduce yourself, and take a deep breath and step back. And this take a deep breath and step back will allow you to think about structure and force you to not forget that first step, which is to look or to inspect. For the patient, you want to check their identity. So get them to answer their name and their date of birth. Get their permission. So are they happy for you to examine them? And give them a little bit of information about what that would involve, and positioning them appropriately. So for a lower limb examination, this is probably going to be starting with the patient standing up. So you can have a good inspection, but the rest of the examination will probably be completed with the patient on a couch. Again, for upper limb, for shoulders, you're going to want the patient standing up because you want to see what that limb is like hanging naturally and probably in enough space. So when they're moving their arms, they're not going to crash into anything. Hands, you'll want them rested on the table in front of them or on a pillow. Exposure as well. So do make sure you expose the patient adequately. In an OSCE examination, the patient will be prepared. They will know what's expected of them. So again, say it with confidence. So I'd like to have, for a shoulder examination, you would want to see the upper chest and the upper back, so all of the scapula. So in a vest, if it's a lady perhaps, or some underwear, or a man to have the t-shirt off. And say that that's what you want. And if they say, for this, the purpose, they can well say, for the purpose of this examination, assume the patient is exposed. That's fine, but say what you would like in real life. For hips and knees, so for knees, you want to have the whole of the knee, the quadriceps exposed, so patient down to their underwear. For hips, you do want to be able to examine all the hips. So underwear is fine, but you might need to move them out of the way, perhaps to make sure you've had a look at all that joint. And then confirm whichever their symptom presented with, be that pain or swelling. So looking, first of all, so we've talked a bit about looking so far, so exposing the patient and positioning them. Look around the bed, any mobility aids, have they got any orthoses, special footwear, slings or anything like that? And gait, so this is partly into the function for lower limbs and also for spine, but have a look at their gait, get them to walk up to the other side of the room and then walk back. And then also, what good thing is with joints, you've got two of them. So you've got two shoulders, two hips, two knees. So comparing left to right is a really good indication of whether something is wrong with one side. And you'll be looking for all of these things. So position, deformity, swelling, redness, skin lesions, any scars, particularly arthroscopic scars might be very small. So you might need to look up close for these. But knee replacement scars go right over the front of the knees, and then hip replacements is on the lateral aspects. So make sure you're looking in the right place and know where to look. And then muscle wasting as well, of the muscles contributing to that joint. For hips, any swelling, because it's quite a deep set joint, quite a lot of soft tissue around it, you might not notice the swelling so much. But obviously you still want to be aware of that it could be swollen. The next step would be to feel. So you want to feel for temperature. And again, with purpose, you're going to feel all of that areas of the joint for the temperature. All around the knee, so over the top of the kneecap and around the edge. You might want to feel the muscle bulk, so quadriceps in particular for knee examinations. And then you're going to want to feel the joint itself. So you want to feel the entire joint, and all the contributing structures as well. For the shoulder, you want to feel all the way along the clavicle. You want to feel for the acromion, which is just below the clavicle and the outer third. You want to feel for the coracoid process. You want to feel the acromioclavicular joint and then along the spine of the scapula as well. For the hip, you want to feel laterally, but that's more for something like trochanteric bursitis. The joint itself is you'll be feeling in the groins for any tenderness. For the knees, you want to feel all over the patella, the tendons, and the joint line, which is laterally and into the popliteal fossa as well. Notice any tenderness, notice any swelling. Is it bony? Is it soft tissue? And in this point as well, you might want to do tests for knee effusions, which is your patella tap test and your sweep test. But I'll talk about them a bit more when we get into the special tests. So the next step is going to be move. So active movement, so get the patient to demonstrate the full range of movement and think of all the movements that that joint can perform. And then also passive as well. So passive movement. So if the joint is limited in active movement, then you're definitely going to want to do the passive movement. You probably demonstrate it anyway, even if they're not limited. And you're looking for any pain, you're looking for the range of movement, and you're also feeling that joint when they move it for any crepitus. So the special tests. So as I said, that it depends on what is expected from you from your university or institution for what is needed for the special tests. It might be that you say you would like to move on to doing some special tests, and they'll sort of stop you there and say, okay, all right, that's fine. What would you perform? And then you would have to know of these tests in order to say what they are. You might say, I would like to go on and perform X test. And then they will say, okay, that's fine. Don't do it, but please tell me how you would do it. So again, you need to know how it's done for that reason. They might say, sure, go ahead and demonstrate it, or they might not be interested in them. Or it might form part of the questions after you've performed the examination. So I think they're really important to know of, but the most important thing is knowing the look, feel, move, and knowing what abnormalities you might be looking out for. The special tests, I think it varies depending on where you study as to what they will be expected. But function, on the other hand, is very important. You need to be able to demonstrate function. So think about what that joint should do. So your hands, obviously, we do a huge amount with our hands, but some nice, easy things. So if there's a pen on the table, you might want to see the patient if they can write, and that's the tripod grip with the 3 fingers. Pincer grip, so picking up a penny or something small on the table. And also pincer grip might be used for undoing and redoing a button or a zip up and down, and that will show you that they can do what they need to do with their hands. Shoulders, hands behind the head and hands behind the back. So that sort of demonstrates all of the movements that your shoulder can perform. If you put hands behind the head, that's showing almost all abduction, abduction, and external rotation as well. Putting hands behind your back, which might be used for dressing, that is almost all of the range of internal movement, and it's sort of a fair degree of adduction as well, and also extension as well. So they're quite good sort of screening tests as well for any limitation. And then lower limb, it's gait, getting to see their gait with their function. So I've now got some Menti questions about special tests, and we'll talk about them a little bit more. So there's a couple of pictures, and if on Menti you can say what you think these tests are for. So this is the Thomas's test, and there's a diagram of it there. If on Menti, I think you should be able to say what you think it is.
If you press the S button, then you should be able to see responses coming through.
Okay. Oh, there you go. So you can still see.
Thank you.
Try not to look at the screen as you do it, because once a few people start answering one, I don't want everyone to copycat.
Sorry, if you press S again, then it'll hide everyone's answers, so you can press one. Sorry, I should.
Oh, that's okay. That's all right.
Thank you.
Although, you know, use all the resources available to you, and if you can see that the right answer's on the screen. Okay, we'll have a look now. So yeah, so everyone's answering the so there we go. So the Thomas's test is for hip fixed flexion deformity. So if I go back to the previous slide, which one is S? So you can see what the clinician is doing now. So they're putting their hand underneath the lumbar lordosis. And what this does is prevents the patient tilting their pelvis and arching their back, which will affect the position of the hip. So you put your hand underneath there, and then you get the patient to flex their hip as far as they can. If that lower leg, so what should happen is that lower leg is able to stay resting flat along the table. If the hip comes up, that suggests there is a fixed flexion deformity, and you repeat that on both sides. And that's one of the special tests for the hip. The other tests there, so the gluteus medius weakness and then the two knee ones we'll come on to in a moment. Just there's no specific test for the knee fixed flexion deformity. That's just on your inspection and asking them to extend their leg. But the other ones, there'll be special tests for, so we'll come on to those. So your special tests for your hip, so true and apparent leg length. So if the clue that you might need to do this is if there's a tape measure in the room. So your true and apparent leg length are measured from different points. So your true leg length is measured from your anterior superior iliac spine. So obviously this is the back of a patient, but from here on the front down to the medial malleolus of that leg. And you measure that on both sides and compare if there's any difference. There may be a difference if that patient has joint disease, which is affecting sort of the acetabulum or the length of one of the bones. So perhaps if they've got a fracture, there will be a true leg length discrepancy. And then apparent leg length discrepancy is measured from a point that's further up in the midline. So either the umbilicus or the xiphisternum, and then you measure from that point to each of the legs. The Thomas's test we've talked about, and then the Trendelenburg test. And this is with the patient standing. You'll put your hands on their hips, so on their iliac crests, and you'll ask them to lift one of their legs just behind them. So don't lift the leg up in any way, just take their foot off the floor. If there is any gluteus medius weakness, the sound side, so the good side, will sag. So if you're putting your hands on someone's hips and they lift up their left leg or lift up their left foot and the left side sinks, there is a problem on the right side, so the side that they are standing on. So make sure you get that round the right way. And then again, you'll compare it on both sides. What is meant to happen is that gluteus medius is meant to compensate when someone lifts their foot off the floor to hold the pelvis level. But if there is weakness, then that won't happen. And then you will end up with the sagging when they walk. And it's got quite a characteristic gait as well. So special tests for the knee. So I've already mentioned joint effusion. So the patella tap test is used to demonstrate if there is a large effusion. It won't be a positive finding if there's a small effusion. The sweep test will show up if there is a small or a large effusion. The best thing to do, I'd say, is look at some YouTube videos on how to perform these. But essentially what you want to do is you want to move all the fluid out of the sort of surrounding area of the knee into just behind the patella itself so that you can see where it is. And that's sort of the basis of those tests. It's quite difficult, obviously, on a webinar to show how they're done. Again, with the ligament tests, again, watch some videos. That's probably the best way to learn them. And practice as well. So with the ligament tests, it's all about where to place your hands and how to hold the leg, which you can end up getting yourself in a bit of a tangle. So give it a practice and then try and get it slick, those movements between the different positions. So your cruciate ligaments, the ones within the knee joint, between the femur and the tibia, you've got your anterior and posterior cruciates. The anterior cruciate, you will do an anterior draw. So that's the top picture here. So with the leg flexed to 90 degrees, you pull it forward to see if there is any movement. Lachman's test is very similar. This is also for anterior cruciate ligament, and it's essentially the same test, but the knees flexed to 30 degrees rather than 90 degrees. The posterior draw for the posterior cruciate ligament is the same as the anterior draw at 90 degrees, but you're pushing the joint backwards. And you can also just observe to see if there's sagging of the knee joints when it's flexed to 90 degrees. Is the tibia and fibia, are they hanging backwards? And the collateral ligaments, you're pulling medially and laterally. And seeing if there is any opening on the medial or lateral side. And then we won't talk about McMurray's test because I think it's being used less and less in general for assessment of menisci. So here's another Menti question. So what special test is this demonstrating? So we're looking at the special test for the upper limb now. What is this one? Do we know? It should be a multiple choice on Menti, and I'll open up in a minute. Yeah, I thought there'd be a bit of a variety on this one. So the upper limb, so for the shoulder in particular, the special tests are quite complicated. So I think that's sort of expected there. So I will reveal the answer. Oh, still got a couple coming in. So I'll talk about, so it's the Tinels and the Farlands test are for the hand. The Nears and Hawkins-Kennedy are for the shoulder. So there we go. So the correct answer for this one is Nears test. So well done, most of you got that one right, but I can fully understand why there's been a bit of a variety in this one. So I will go on to show you these ones. So for the hand, so we haven't talked much about the hand examination, and that's because it's a little bit different to sort of the large joints. In the hand, you've got so many little tiny joints and all of them need to be examined. You need to feel every single one. You need to move every single one, although your examiner will probably stop you and say, thank you. Yes, we can move on to the next part. Hand examinations, you will probably assess the neurovasculature, and that's because it's so tightly linked with the function. So the sensation of the different nerve areas, so your ulnar, radial and medial nerves, and also your you assess for pulses as well. For carpal tunnel syndrome, so you've got Farland's test, which is pressing, and these pictures are from a physiotherapy YouTube site, which I found quite handy for demonstrating each of the tests. So Farland's is press, starts with a P, even though it doesn't sound like it, and Tinel's is tap, so tapping on the over the median nerve and see if it gives the sensation down into the hand of their carpal tunnel syndrome. And then the shoulders, as I said, this is a little bit where it gets really quite complicated. I think in different places it's taught in all sorts of different ways. This is the way I was taught, and this is the way I have remembered it, although I have seen people use all sorts of different tests, especially for impingement. So shoulder impingement is impingement of the muscles of the shoulder beneath the coracoacromial arch, and it can be quite painful and restricting the movement. So that diagram previously of the arm being turned inwards and abducted is Nears test. So you turn the thumb downwards and then you abduct the arm, and it will cause symptoms of the impingement. Hawkins-Kennedy, again, easiest if you just look at a YouTube video, is shoulder abducted to 90 degrees, elbow flexed to 90 degrees, and then you internally rotate. So a similar sort of movement of internal rotation to test for impingement. And then the scarf test is just using the arm as a scarf, and does it cause symptoms of impingement? The rotator cuff assessment will be part of your move for the shoulders. So you will assess the movement and you'll also assess their power at the same time. So supraspinatus is involved with abduction of the shoulder. So you really test power for that. Infraspinatus and teres minor are external rotation. So you will assess the power for that. And subscapularis is, infraspinatus and teres minor are external rotation. Subscapularis is internal rotation. So as part of your movement, you will assess power. So the rotator cuff assessment will probably form part of your shoulder examination, and will be part of the move section, and you'll just assess the power of those to see if there's any tears to these muscles or any pain significant when they use them, which might suggest there's perhaps some impingement. And instability, these are a couple of tests for if someone has a recurrent dislocating shoulder. And these are a couple of things. So sulcus sign is where the arm will be, you will sort of stabilize the shoulder and you will pull downwards from the elbow and see if there's a sulcus that forms, suggesting that the shoulder's subluxing. Anterior and posterior jaw, you will be pulling and pushing forward while stabilizing the joint to see if there is any subluxing forward or backwards. An apprehension, so someone who has dislocated their shoulder on numerous occasions, if you start to externally rotate when it's abducted and the elbow is flexed, the test is not, you're not trying to dislocate the shoulder, but your patient will be very apprehensive. They will be aware that that movement is not good and they will probably stop you before you get too far. So shoulders a little bit more complex. There's quite a few different steps to shoulders. As I said, I don't know whether you'll be expected to perform all of these, but it's a good idea to have just a knowledge of, say, a couple of impingement tests, a couple of instability tests, so that if you're asked either to perform them or what you might want to do, you can do. So the last thing you're going to do is you're going to want to wrap up your examination. So you'll thank your patient, you'll allow them to redress and wash your hands. You'll then turn to your examiner and summarize your findings. Again, so with summaries, you want to have a structured approach. You want to talk about the positive findings and you want to talk about any important negative findings. You might want to offer some differential diagnoses, or you might be asked about that. And to complete your examination, you'll want to examine the joint above and below. So for the shoulder, the joint above will be the C-spine, below obviously the elbow. For the hips, the joint above will be the lumbar spine and the joint below the knee, and then the knee, obviously the hips and the ankle. You will offer to do a neuro assessment and assess the vasculature and perhaps investigate. Generally a good idea to start with an X-ray, since it's quite a simple, non-invasive, straightforward, quick, easy test, and can rule out some quite common, or can assess for some quite common problems. Obviously fracture, but you'd like to think that'd be quite apparent, or osteoarthritis. And then perhaps an ultrasound or MRI if you're particularly concerned with a soft tissue assessment. So I think that's everything for the joints. As I said, quite a whistle-stop tour of quite a lot of information. And I can answer, hopefully, any questions that you've got. But falling back on a structure is probably the most important thing, and having an awareness of some of the special tests.
So the first one, any tips on how to examine hand joints for RA and OA?
Yeah, so hand examinations, as I said, there's a lot of joints. I haven't counted. It's probably something for a pub quiz, knowing how many joints in the hands. But you do have to palpate. So starting off with the wrist, and you want to palpate if the carpal bones, metacarpopharyngeal joint squeeze across here. And then examining, so bimanual examination. So your hands sort of like this over all of the joints of the fingers and of the thumb. So there's a lot of joints to examine for. There are some quite key sort of spot diagnosis findings, and certainly what we do for some of our mock OSCEs is have some spot diagnosis photographs. So even if your patient has a normal hand examination, some of the spot diagnoses on photographs saying what might be going on with this patient. So for rheumatoid arthritis, again, less commonly nowadays because there's much better treatments for rheumatoid, but ulnar deviation, so the fingers deviated towards the ulnar side, so that way is common for rheumatoid arthritis. You've then got the position, so the Z thumbs and the swan neck and deformity, so just beware of which way around they are of the fingers. And then for osteoarthritis, your Heberden's and your Bouchard's nodes, so Heberden's up here and Bouchard's nodes down here, are key findings for, and that's sort of that's the classic sort of bony swelling. So the joint is swollen, but it's not a soft tissue swelling, it's a bony swelling. And if they've got particularly active disease, so flare up, especially of rheumatoid arthritis, they might be inflamed as well. So they might be red, warm, and very tender as well.
Brilliant, thank you. We've got loads coming through now. The next one, if the patient's in pain, how do you proceed?
So just carefully. So is the pain to such an extent that they're not going to be able to perform that movement? Or is it something that, so I normally, if someone's in pain, I will say, say for example, you're assessing a range of movement or something, and so you're asking the patient to flex their hip, and they say, oh, I can't go any further, it hurts. And if you sort of take the weight of their hip, so you're taking the sort of stress out of the muscles and things, and say, and I sort of normally ask them, if I were to push this further, would that be okay? Sort of just gently pushing and keeping an eye on them at all times. So if they say, no, don't, then that's quite a clear finding that there's something wrong with that hip. If they might say, oh, it's not so bad if you do it, and then maybe it's something more like a muscular problem rather than a bony or joint problem. But just working with the patient, sort of taking it very, very slowly and very gently, and say, what would happen if I were to push it further? And they might say, I don't know, try it. They might say, no, that will hurt if you push it further. And that's similar with someone with a joint replacement. Perhaps they will know what can't be done.
Brilliant. That's really helpful. Thank you. So just in the interest of time, we'll answer one more question if that's okay.
Yep.
Lovely. So the last one, any tips for an elbow examination? This came up recently in OSCE and we didn't really know what to do.
Oh, so yeah, I don't think I've really come across elbow examinations in particular as one that comes up often. So fall back to your look, feel, move and function. So look all around the joint. I think some things that might classically come up for elbows, so talk about plaques, whether they be rheumatoid plaques, psoriatic plaques, or whatever you might come across over the elbows. Look for any of the things you might normally look for, and especially how is the person holding it. So for upper limbs, people tend to sort of support their joint or their arm if they've got any problems with it. Feeling it again, just make sure you do a good feel around the whole joint. And be aware, just have an awareness of the anatomy. So have an idea of just what you might be feeling for. I think just thinking of pathologies that typically affect the elbow. So your tennis elbow and golfer's elbow are probably some of the most common things that would affect the elbow. So just have an awareness of where you would feel for those. So on the flexor and extensor muscles. And then movement. I mean, there's not much movement you can do for the elbow other than flexion and extension. So yeah, I think even if it's something you've never come across before, if you're asked to examine, I don't know, say if you've never even thought about examining the elbow, which I can't say I have really done until this point, you can always fall back to your look, feel, move, and then what's it meant to do? It's meant to flex, it's meant to extend. And can the person do that? And hopefully that should get you at least a few of the marks on there. And being nice to the patient, remembering your easy marks, so your wash hands, introduction, and then thanking the patient at the end and getting them to redress.